like to introduce the star of the night, whom all of you evidently know. I'm hoping that after I sent you links, you Googled him and looked at all the wonderful things he's been doing, if you didn't already know, Dr. David Gandara.
So thank you, Danielle. So it's a great pleasure to be here. This is the second time that I've spoken at the Living Room. There are a lot of great experiences. It's very uplifting to hear everybody's story. And you know about the Living Room. I hope a lot of you also know that that's only a small portion of what the Bonnie J. Addario Lung Cancer Foundation is about, and also their scientific institute, Alchemy, and their scientific advisory board for making grants. It's just a fabulous organization. And a lot of it revolves around the theme of personalizing lung cancer. And I'll tell you my own perception of how I look at that. I talk about molecular fingerprinting, and I talk about who's driving the bus. Now, this is a relatively new analogy, and it's because of what we call tumor Darwinism. And then the next one I call of mice and men. And we're doing a fabulous project with the world's most famous mouse cancer doctors at Jackson Laboratory. And that's being partially funded by the Bonnie J. Addario Lung Cancer Foundation. So I want to tell you about what we're doing with mice and how we think it can help patients. And then the last one I call forks in the road. And that's really about all the choices that cancer patients have to make. And when you're at one of those forks in the road, you know, how do you decide which way to go? Everybody knows about fingerprints, and just about everybody in the room probably has heard that no two people have exactly the same fingerprint. I make the analogy that that's much like your cancer. Believe it or not, nobody has a lung cancer that is exactly like somebody else's, no matter what you may hear from anyone. I heard so many people tonight talking about they got molecular testing or they're on Tarceva because a mutation was found in their cancer. That's just the first step in all of this. About 10 years ago, this is how stage 4 non-small cell lung cancer patients looked to their oncologist. If you see all these cartoon figures look exactly the same, they're all the same color, and if an oncologist had a room full of lung cancer patients who were stage 4 and they were non-small cell lung cancer, they all got treated the same way. So what's happened in the last 10 years is we found out that these are actually different. And so this patient up in the left-hand corner, for example, is a 65-year-old male. And this patient has some specific abnormalities in the cancer that now we can use to treat that cancer. And the first one of these is what's called a KRAS mutation. I didn't hear anybody mention that in the room tonight, but we now have several new classes of drugs against this mutation. So just like Tarceva is against a mutation called EGFR, and crizotinib is against a kind of a mutation, a fusion, called ALK, we now have drugs for KRAS. And we have 3 clinical trials at UC Davis all going after that particular gene. And it's a nasty one. In other words, it's one that doesn't respond to Tarceva and so forth. The other thing that this patient has in their cancer is they have a high amount of a gene called ERCC1. And what that gene does is, in theory, it's good for you. It allows, if you have cells in your body that have been damaged, let's say you have a sunburn, it allows your bodies to repair the damage to those cells. But if the cells are in a cancer, that means when you get chemotherapy, like carboplatin, and you have a lot of this gene in your cancer, that means your cancer can repair the damage and the cancer cells don't die. So again, here are 2 genes where we're finding we can use this information to treat cancer patients. Well, this patient up in the right side is a young woman, 39 years old. Now, Bonnie, and we've had patients in this living room before who are in their early 20s. So 39 may seem young. It's not anywhere near the youngest of the patients that we're seeing now with lung cancer many of whom have never smoked and don't even have secondhand smoke. So that's another story. And this particular patient does have one of these EGFR mutations, like several of you in the audience do. And so that's a good patient to treat with what we call erlotinib, you call Tarceva. The point I'm trying to make is that these are not the same patient. They're all very, very different. And today, in 2013, oncologists who know about lung cancer will know that they're different, and they're going to treat them very differently, just the way a lot of you in the room are being treated differently because they found these abnormalities. This shows how we used to think about non-small cell lung cancer. The circle's all blue, one disease. And then we said, well, there may be some treatments that work better in adenocarcinomas versus squamous cell cancer. And then we have a group called other. So whoever had the large cell neuroendocrine, that's the other. And that we could do better by treating certain patients differently if they had this. And so here's where we are today. And you can see the pie is getting divided. Whether it's adenocarcinoma on the top or squamous cell cancer on the bottom, you can see that a lot of the pie is filled in with different genes. And this means either the gene is mutated or there's too much of it or it's altered in some way. And now we have drugs against essentially all of these. You can see there's still an unknown there. And this slide was made about 4 months ago when we submitted the article. It's already out of date. In other words, we've found more since then. So some of these are what we call drivers. They drive the cancer to grow, and that's what's called an oncogene. So you can see EGFR mutation is an oncogene, KRAS mutation is an oncogene, ALK is an oncogene, and then over here, P53 is the opposite. It's what's called a tumor suppressor. It's actually something that keeps you from getting cancer. And sometimes you lose that gene, and that's why you got the cancer. So a lot of the drugs we have now are going after the oncogenes because that's something you can go after. When you've lost a gene, you have to replace it. And so we have to find some way of trying to go against the tumor suppressors. And some of you that have been my patients know the way I describe this to patients is I talk about driving a car, and I say you have an accelerator and you have the brakes. So oncogenes are like the accelerator is always on. In other words, the accelerator is stuck to the floor. The cells are supposed to be going through a cycle. They grow a little bit, they stop dividing, they die off. Instead, if you've got that oncogene in your cancer, like an EGFR mutation, it's always on. And so you can turn it off, like a light switch. Some of the people, I think if you were on Tarceva and you had symptoms, some people, or Iressa, which is kind of like the granddaddy of Tarceva, you might have noticed that your symptoms got better right away. And the first time I ever gave anybody Iressa many years ago, he called me about a week after he started the drug, and he said, my cough is gone and my breathing is better. And I said, oh, this is the placebo effect. It couldn't possibly work that fast. And it turns out it can because it's an oncogene. Now, on the other hand, those tumor suppressor genes are like you've lost your brakes. And so the tumor is growing, in this case, not because the accelerator is stuck, but because you have no brakes. And so again, that's a lot harder right now to try to see how do you restore the brakes on that cell. Then the next thing I want to talk about is what we call tumor heterogeneity. And heterogeneity just means differences. The traditional view was that everybody's cancer was the same, so all the cells are blue, patient A, patient B. We know now that between patients they can be different. So that's this interpatient, between patients. So you can see one patient's cancer cells are blue and other ones are red. That's to represent different kinds of genes. The newest thing here, and this is what is becoming really important, and this is the reason your oncologist may say at some point, we have to rebiopsy your cancer, is that within one patient's cancer, there can be multiple abnormalities, like I just showed you, with all these abnormalities, and it can change over time. This is what I call tumor Darwinism. If if you have a cancer and it changes over time, is it because there were some cells there in the very beginning, like those red cells in scenario 1, that then under treatment you suppress the blue ones, then the red ones come out? Or is it because something brand new comes out? Like on scenario number 2, you have the green. Even though this sounds maybe a little overly simplistic, this is what we're actually trying to figure out now. How often is it scenario number 1? How often is it scenario number 2? So knock on wood, Dr. Kamage and I just got a big trial approved by the National Cancer Institute. It's just going through the final approval in ALK cancers to test this very thing and figure out what happened. And the way I explain this to my patients is to use the analogy of who's driving the bus. So everybody knows you have a bus, you have one driver, you have a bunch of passengers. So you remember when I mentioned the oncogenes were like drivers? So think about that, is you've got an EGFR mutation driving that bus.
So are the other ones saying, hey, turn right, turn left,
Sometimes
slow
they are,
down?
because they're influencing the EGFR. Very good, Bonnie. Bonnie knows too much. So, you know, I use the analogy of a bus, and I say, okay, we've got a driver here. All of the rest of the genes, because we're talking about genes, are passengers. They're along for the ride, although some of them, as Bonnie said, may be backseat drivers. They may be actually influencing the driver, so they're important to know about. But if we do the biopsy and we see all of these genes, we have to figure out what's the driver and what's the passenger. So let's say then your cancer gets treated and you get a good remission, but then after some period of time it starts to regrow. We may want to rebiopsy because we want to find out, is there a new driver? Is it still that same old driver and we have to figure out now why it's become resistant, or is it something brand new? And so Dr. Kamage, believe it or not, found out in some patients with the ALK gene, the ALK fusion in their cancer, they got a drug called crizotinib, they got a great remission. A year later they relapsed and he rebiopsied about 20 of them. And what he found out is that some of them no longer had the ALK, and instead, guess what? Some of them had the EGFR mutation, and they could actually now get Tarceva. Some of them had that KRAS mutation, and they could get those drugs I talked about that go after KRAS. So this really turns science on its head. Yeah, so this is really fascinating, but it tells you the complexity we're dealing with. Again, these are smart cancers. And to switch drivers for a cancer just is absolutely phenomenal. But it's what you would expect, perhaps, if you had a bunch of small birds on an island like the Galapagos and several hundred years went by and they weren't, you know, mixing with any other birds. So it really is, again, like a Darwinism.
Dr. Gandara, I have a question from somebody online saying, it's been 6 months since my sister's first biopsy. We are told that you don't rebiopsy during non-progression. Is that true? She's been on Tarceva for 3 months with success.
I would agree with that.
Yeah.
So remember when I mentioned before, we have to figure out if you rebiopsy, when you rebiopsy, is it safe to rebiopsy, and so forth. So ordinarily, if things are going great, that means that you've still got that driver under control. And it would only be when the cancer starts to regrow that you would consider doing a new biopsy, because that's when the new change would be there. Otherwise, you might just be wasting your time to do the repeat biopsy. Sometimes if the biopsy was never done in the beginning, even if the patient is stable, we'll still do a biopsy because we want to find out, even if they're doing okay, is there something there that we could have actually done more with? But if they've had molecular testing in the beginning, then for the most part, you wouldn't do it again until they progress.
So I actually have a question about that, since we're talking about rebiopsying. Let's assume a patient has a mixed result, right? So most lesions are stable and or have shown regression, but one is continuing to grow. Do you go back and biopsy that one spot to try to find out what might be different, or?
So I'll add, so now Danielle knows too much. So, pretty soon they won't even have to have a speaker.
Not true, not true. So not true.
This is a big controversy. And what it means is that, a metastasis, that means cells got out usually into the blood, they traveled around, they found a nice new home somewhere. Sometimes it was the bad actor that did that. And the rest of the good cells that only have that single driver are still sitting there repressed. So yes, in theory, and as a matter of fact, we ask oncologists about where they would biopsy under different circumstances. And we had a panel of a dozen lung cancer experts. And we said, if you have a choice of biopsying the primary, in other words, where the cancer started, or a metastasis in somebody who has stage 4, which would you choose? And so we asked about 350 practicing oncologists in the United States. 80% of them said biopsy the primary, because that's like the mothership.
Oops.
Every one of the experts said biopsy the metastasis, because that's the bad actor.
Yeah.
So just about through, I want to talk a little bit about the of mice and men. It shows what we're doing with tumor specimens in patients that we biopsy at UC Davis with lung cancer to figure out the genetics and to be able to develop new treatments. And this is a partnership with, I mentioned earlier, the world's most famous mouse cancer doctors, and that's called Jackson Laboratory. They only do laboratory research, and they do it with mice that are not house mice. These are specially genetically bred mice so that you could put a cancer onto that mouse and it will grow. Where ordinarily, if it's a regular mouse, it would reject it, just like people reject transplants because it's foreign. Well, these mice will take that cancer and we can grow them, and then a patient, one patient, may have 40 mice, all with her cancer in it. And you can imagine then that we can do many things in terms of looking at different treatments or genetic changes in those mice, because then basically that person's cancer is there forever. We can even freeze some down and thaw it out later, put it in a new mouse so we can have it again. And we put it through a whole series of tests. If it's a small biopsy, you only get one mouse. And so if that mouse kicks off, then you've lost the tumor. I had to tell one poor patient last week, everybody comes into my clinic, they don't say, how am I doing? They say, how are my mice?
How's my mouse?
And so this one we only had one mouse and that mouse died, and it was just terrible. But sometimes the cancer kills the mouse. Sometimes, the mouse just goes belly up. But if we've got 10 mice, then we're going to have some that survive, and then pretty soon we've got 40 mice or 50 mice or whatever we want. So you can see a patient gets a biopsy, we put it into a mouse, we grow it into a bunch of mice. That little canister up there is a freezer, so we freeze down some so we have it later. And then all the blue and red lines there, that shows all the genetic testing that we're doing. And then we develop these, what we call models. And so you can see over on the left in red, we have 9 different patient cancers that are KRAS mutation, so forth. And then for the EGFR, each one of these, LG0628, is a patient. And you can see for one of these patients, we have the same patient when they initially presented their cancer. We did a biopsy. And then later, once that patient failed Tarceva, which all of these patients got, we did another biopsy. So now we have her cancer resistant versus sensitive, and we can do testing to show what the best treatment might be and figure out what the genetic abnormalities are. And this slide shows that. This just shows 5 different patients and the status. All of these have that EGFR mutation, whether it's sensitive or resistant. And then you can see regimens A, B, C, D. We can do this, and we can do genetic testing before we give it the drugs and after we give it the drugs and figure out what the best regimen is. So in theory, this could help that patient. But in reality, it also allows us to develop a scientific tool that may help thousands of patients. Because as I mentioned earlier, even though all these molecular fingerprints are different, there are certain drivers that are going to be more common or less common. And if we can figure out what the most common are, we'll have a better idea about what the next treatment should be for all the patients, even though we're focusing just on some. And we can also figure out what's not going to work in certain situations. And this is how a lot of us are thinking we will be looking at lung cancer in the future. You have a patient, she's got her genetic profile, her sequence. She goes into the pharmacist, she gives it to him, he puts it in a computer, and he gives her pills back that are specific for her cancer. Okay, I want to say a bit about clinical trials because despite all the information out there, I think there's still a lot of misinformation and a lot of patients who are afraid of clinical trials. And one thing that they're afraid of is randomization. And I think this slide shows why we do that in some trials, not all of them, but in some trials. And you can see that there are some characters here. These represent, let's say, different drivers or different genetic abnormalities. We want them to be balanced in two arms, one of which gets what's called the standard of care treatment, and another gets either the standard of care plus something or a different treatment. And at the end of the day, we want to figure out which one is the best. So this would be how you do a phase 3 trial. Now, a lot of patients say, that's all I want. I don't want those phase 1s. I don't want the phase 2s. I want the phase 3. That's now a misperception because the drugs we've got now are incredibly more effective than they were 20 years ago. So, for instance, crizotinib for the ALK patients was approved based on a phase 1 trial. So the people who said, I don't want that phase 1 trial, I'm going to wait till it's phase 3, they missed out. Actually, MD Anderson did an analysis and found out that patients going on phase 1 trials had more remissions, lived longer than patients getting whatever their doctor thought was the next best thing. So again, patients shouldn't be afraid of that. Also, placebos. Usually we don't have placebos in our trials, unless it's something like this, where one group is getting like the very best treatment you could get plus a placebo, and the other group is getting the very best treatment you could get with a new drug. So you're still, one way or the other, you would still be getting whatever the best treatment is that's available. So the problem with clinical trials, even though I said all the good things about them, is they want a population that don't have all these other ailments that people get. And so sometimes that means if you have a bad heart or bad kidneys or something else like rheumatoid arthritis, it's going to be difficult for you to get in a trial. And the reason is they're concerned either it's going to make those conditions worse or somehow you're going to be different from the other patients. And at the end of the day, they're not going to know what to make of how the trial did in you.
A lot of the people I know who are doing clinical trials are of the opinion that it's not a last resort, it's their next best hope.
I agree with that 100%. Well said.
And you have to consider that at one time Tarceva was in a clinical trial, and crizotinib was in a clinical trial, and combinations were in clinical trials, and those patients were the first to get them. So less than 2% of cancer patients participate in clinical trials. And we need to really think more positively about this whole process.
And that's part of the reason, just without belaboring this, that we take our message out to the community and practicing oncologists and things like the virtual tumor boards, because we want to make them know about these new trials and the excitement, and you could test your patient and see if they can go on a trial. Because otherwise that oncologist is pulling something off the shelf for his patient, which he thinks is the next best thing. But in reality, he knows has a very low chance of helping them.
How does that work where you would say, you know what, you really should be at UCSF for this trial? Is that, how does that work?
So there are multiple ways. One is that because I'm a lung cancer specialist, I know about the other lung cancer trials. If there's something else that we know about, we'll refer the patient if we think that's the best thing for them. Number two, we have a person called a clinical trials patient navigator. Corinne. Some of you have spoken to Corinne on the phone. That's her job, is to know what trials we've got and kind of take your background and see if it matches with our trials and also to know what else is going on. But a good resort also is to go to the clinicaltrials.gov and see what you've got there, because in theory, that's every trial in the United States that would be going on for lung cancer. I've been giving you a lot of messages about the future and genetics, but a lot of what we do with, as physicians and especially as oncologists, is we try to share with patients our perceptions about how they deal with the cancer and not letting cancer take over your life, but trying to empower yourself so that you still can live the very best life that you can. And that's what I call the forks in the road. And how I explain this to my patients, some of you have probably heard this, is that everybody, when they first come to see me, it's like, what about next week? What about my next scan? And I tell them, look, this is not a 100-yard dash. This is like running a marathon. You've got to make it all the way through. You've got to take the long-term perspective on this. And along the way, there are going to be these forks in the road. Confused, lost, unclear, perplexed, disoriented, bewildered. They're no good signs, right? No matter which way you go, it seems it's not the right choice. And I think this is true very often in oncology and in lung cancer, is there's not a clear-cut way to go. And my patients will be stewing about it, and they'll be, thinking, oh, if I spend enough time thinking about this, I'll figure out what the best thing is. And I will tell them very often, I'll say, we've got choice A and we've got choice B. This is like oranges and apples, but there's not a clear-cut one that's better. What do you feel most comfortable doing? And that's what we'll do. On the other hand, if it's clear to me that going down that path on the right is absolutely the best thing to do, then I'll tell the patient that, and I'll say, I advise you to do this. But at the end of the day, they're the patient. And I always say, this is my advice, but you're the patient. You have to tell me if this is acceptable to you. And sometimes patients say no. I want to go on a world cruise, or I want to do whatever. I have a patient meditating in Thailand right now. And then the last there is just this empowerment about the better informed you are, the better prepared you will be for this journey, because having cancer is like taking a journey. I try to answer their questions. And if a patient has questions, if your physician acts like he doesn't want to explain it to you, he doesn't want to talk about it, you really need to kind of like take them by the lapels and say, look, this is really important to me. If you don't have enough time today because you have 20 other patients, tell me when I can come back that you can explain this to me. Because the better informed you are, you're going to be more comfortable with what's going on, and you're going to be more comfortable making decisions and making that journey.
I don't even remember how many years ago it was that I met Dr. Gandara for one of the first times, and I have had nothing but the utmost respect for him, not only as an amazing physician, but as an amazing human being. So I want to thank him very, very much for taking time out of what I know is a very busy schedule to come here and spend this time with all of you. So thank you.